Sé que es tarde, vamos a empezar nuevamente para no retrasar más el programa. Entonces, bueno, le voy a ceder la palabra al doctor Francisco Montión para que presente al doctor Kopple.
Bueno, pues muchas gracias. Bienvenidos a esta última sección de esta primera reunión de la ciudad de egresados de aquí de Nefrología del Hospital Despedida del Centro Médico Nacional de Occidente. Y es para mí realmente un honor otra vez presentar a nuestro invitado, el doctor Joel D. Kopple, que como les comentaba, él es nefrólogo, no necesita mucha presentación, con un historial académico increíble, formado en Northwestern, en la Universidad de Chicago. Y él va a hablar en un tema, ¿verdad?, que siento que es muy de actualidad, es una actualización, cómo se evalúa y cuál sería el manejo en la situación, ¿verdad?, de fragilidad, en la enfermedad renal crónica y trasplante, una situación, ¿verdad?, que es de extraordinaria importancia, dado que estamos viendo y estamos manejando un buen número de pacientes con estos diagnósticos que son realmente frágiles. Y ustedes saben, todo el mundo sabemos, ¿verdad?, que esto los disminuye en la situación de respuesta al tratamiento adecuado, ya sea con falla renal o incluso están enlistados para lista de espera. Entonces, él nos va a actualizar y nos va a hacer recomendaciones cómo podemos manejar esto. Thank you, Dr. Kopple, again for your kind acceptation to come with us, and then it's a pleasure. Okay, the stage is yours, okay, please.
Thank you very much, Dr. Montión. It's a great pleasure for me to be here. See, I'm pressing this and nothing happens. I'm pressing here and it doesn't move. Look, this has got to work. So can you move it there? I'll say next slide and you move it, okay? Okay, next slide, please. Okay, well, my goals for this presentation are as follows. It's to define protein energy wasting and frailty and their interconnection. Briefly discuss the causes of protein energy wasting, but then provide evidence that in end-stage kidney disease and kidney transplant, there's a high prevalence of frailty. Frailty is associated with increased morbidity and mortality. Frailty is treatable, and to make some comments about what is known about the treatment of frailty on clinical outcomes in kidney transplant recipients. Now, protein energy wasting is defined as the loss of somatic and circulating body protein and energy reserves. We use the term protein energy wasting rather than protein energy malnutrition because some causes of protein energy wasted are entirely unrelated to inadequate nutrient intake. The causes include reduced nutrient intake, malnutrition, anorexia, increased nutrient needs, such as in the dialysis patient or the transplant recipient that is receiving large doses of glucocorticoids, nutrient losses in dialysate and urine, including nephrotic patients, the catabolic illness and inflammatory states. This is a very big cause of protein energy wasting and is not directly related to nutrition. The uremic milieu, acidemia, and physical deconditioning and sarcopenia, very common in our advanced kidney failure patients. Now, there are the diagnoses for protein energy wasting there are many. They include subjective global assessment, the malnutrition inflammation score, inflammatory status, prognostic nutritional income, which is a serum albumin plus 0.005 times the total lymphocyte count, muscle strength or function, such as hand grip strength and gait speed. Now, why are we so concerned about protein energy wasting? The reason is that there are many studies indicating from many different laboratories that protein energy wasting is associated with all-cause death. This is one example of this, published a couple of years ago, where the prognostic nutritional index was used as an indication of protein energy wasting. The data were derived from over 100,000 patients who began maintenance hemodialysis in the United States between 2007 and 2011. And as you go up this curve, this is people with very little wasting, and as you go to the dash line, the dotted line, and the dotted dash line, you go to progressively more severe protein energy wasting. And you see that over a period of 5 years, there was a dramatically greater mortality rate in all, from all-cause death in those who had evidence of protein energy wasting. Similarly, cardiovascular death was significantly greater in those with wasting than those without wasting. Now, I included this in the following 2 slides because of a discussion we had yesterday. And this slide deals with the issue of appetite and inflammation and mortality in a group of 339 maintenance hemodialysis patients. The patients were asked by a nurse to fill out a questionnaire, had one question, all they do is check a box. Was their appetite very good, good, fair, poor, very poor? Nobody picked very poor. And of the other 4, this shows those who picked very good, good, fair, and poor. And you can see that the serum C-reactive protein, which was measured at the same time, nobody knew the numbers of the C-reactive protein when the patients were making these their response. And you can see that the C-reactive protein was significantly higher in those who described a fair or poor appetite as compared to who described their appetite as very good or good. In addition, we found the same thing with regard to the malnutrition inflammation score, also IL-6, although I don't think I included that data. You can see it was significantly higher in those who described anorexia as compared to those who said their appetite was very good or good. Now, beyond that, this is why in my opinion, this should be part of the medical history of any patient, and that is that these are the people who describe their appetite as very good or good, and these described it as fair or poor. Again, nobody described it as very poor. And notice the difference in the survival over a period of 12 months in these maintenance hemodialysis patients. About 98% survival, 97% survival, 96.5% survival versus 86% survival. A really major difference in 12 months just based on how the patient described his or her appetite. Now, when does inflammation and which is again one of the major factors promoting protein energy wasting, when does this begin? Well, this study, which was carried out in almost 4,000 patients with different stages of GFR going from greater than 60 cc per minute down, this is again estimated GFR, to less than 30. And you can see that there is a significant rise in all of these pro-inflammatory cytokines, in high sensitivity C-reactive protein, in fibrinogen. In serum albumin didn't rise, it fell, because albumin is a negative acute phase protein. In the cytokines, interleukin-1 beta and the interleukin-1 receptor level both rose, as did IL-6 directly, TNF-alpha, tumor necrosis factor alpha, and transforming growth factor beta. All, well, that fell again, a negative acute phase protein. The others, except for albumin, all rose. Please note that even in patients with GFRs of 40 to 59, these values are beginning to rise, even though these patients often look and feel normal. As I said yesterday, people often can look normal, but they're losing, again, with GFRs in the range of about 28 to 32, but they're beginning to lose weight, and large weight loss is associated with mortality. Let's now switch to frailty. Frailty previously was generally applied to older adults and is defined as, and this is a quote, older adults or aged individuals who are lacking in general strength and are unusually susceptible to disease or to other infirmity. Now, frailty is used to characterize people of all ages who are debilitated and who often have other diseases or who are at risk for becoming debilitated. Now, this is the criteria of frailty that was defined by Linda Fried, who published her paper in 2001. This paper was, in English, we'd call it seminal. It led to an enormous reorientation of doctors who care for patients long term. And this has been widely used in the field of nephrology, even though she defined it originally for aged people because she herself is not a nephrologist, but is a gerontologist. And she defined frailty as having 3 or more of the following: unintentional weight loss. And this is, for example, loss of 7 or more % of the body weight over the past 6 to 12 months. Self-reported exhaustion. Measured weakness is determined by hand grip strength or a slow walking speed, a 6-minute walk or a 3 or 6 second walk, and low physical activity compared to normal persons of the same age, sex, or racial, ethnic backgrounds. Now please note that this also is connected to protein energy wasting, because it includes unintentional weight loss. But the other factors are all related to either physical endurance or physical performance, such as walking speed and strength. Again, measured weakness, like hand grip strength, or slow walking speed. Thus, by consensus, frailty is defined by a combination of protein energy wasting, decreased exercise capacity or physical performance, and reduced daily physical activity. Now, there are many other criteria for frailty that generally include the presence of various diseases. And in kidney failure and kidney disease, there are many other criteria for frailty, which I'll come to in a moment. Other disease burden includes heart, lung, or liver failure, emotional depression, other psychiatric illnesses, gastrointestinal distress, and other pain syndromes. If you look at the literature on frailty, particularly if you look at the surgical literature or the gastrointestinal literature, there's a lot of discussion of other types of diseases associated as part of the frailty, but it always includes such factors as weight loss, low physical activity, and reduced strength. Now these are, and I know it's hard to read this, but the reason I put this slide is to show the large number of different fragility indexes that are used in public research publications involving chronic kidney disease. So there are many different ways of characterizing wasting, frailty, but most of them include many of the elements of Linda Fried, which I don't think any characterization of frailty is more effective than the one that she developed. Now, with regard to the Fried criteria, again, frailty is prevalent in the general population in roughly 2.8% of all adults, less than 3%. 7% of those greater than 65 years of age, and 40% of those who are greater than 80 years of age. 40% or greater. Frail people have increased risk of hospitalization, disability, and mortality. Isn't that interesting? That if you have reduced strength and less physical activity, and your walking speed is slow, and you have unintentional weight loss, that you have increased hospitalization, disability, and increased death rate. Now, this I think is an extremely important slide and study, and what they did in this, what Wilhelm did in this study, is they looked at the prevalence of frailty in relationship to chronic kidney disease. And these include the 5 elements that Linda Fried talks about: unintentional weight loss, physical strength weakness, physical exhaustion, low physical activity, and slow walking speed. And it shows the overall relationship in normal individuals that they studied, those without chronic kidney disease. And here you see the frailty in their group was 1.47 of no people without kidney disease. Now this is stage 1 to 2 kidney disease. Already it's increased. Frailty in 5.94%. And you can see the different elements, most of which are increased. What about stage 3A? Frailty has jumped to 10.7%. And again, most of the different elements, not all, but most of the different elements, including weakness, low activity, are increased. These people look normal. There are almost certainly people in this room with stage 3A chronic kidney disease. They look normal. You can't tell them apart. They generally feel normal, but they already have a higher risk of frailty, 10.7%. Stage 3, 4, and 5, it jumps to 21%. And again, most of the elements are increased. Now, why is there so much concern regarding frailty and skeletal muscle wasting in advanced CKD, end-stage kidney disease patients? It's again because I stated that it's associated with such a poor outcome. This is one study from Korea in a group of 46 maintenance hemodialysis patients. 15 of these 46 had frailty and 31 did not. Average age 71.5 years, 63% men. And you can see over the course of 2 years, a clear separation in mortality rate. The survival was approximately 92% at 2 years in those who were not frail, and it was about 68% in those who were frail over 2 years. And this is another study from published 3 years ago that again shows that those who have frailty, in this case, they just looked at body mass and they compared the extracellular component of body mass to the body cell mass. And if you are frail, or in general you have reduced muscle mass, your extracellular volume will be greater compared to your intracellular volume. And those are these people. I'm sorry, what did I do here? Those are these people. So this shows that those people who have evidence of wasting and frailty as compared to those who don't. Their survival, again, maintenance hemodialysis patients over 24 months, even more dramatic than in the study from South Korea. Now, what about frailty in kidney transplant recipients? It turns out that in kidney transplant centers, frailty has been diagnosed in 16 to 30% of kidney transplant candidates. These are chronic dialysis patients, and 14% of kidney transplant recipients. Of the patients studied in a single maintenance hemodialysis unit, of 146 maintenance hemodialysis patients who were classified as frail, again by the Fried's frailty phenotype, Linda Fried, frailty was perceived. These again were all frail people, 146 frail maintenance hemodialysis patients by the Fried criteria. But only 42 of these patients were recognized as being frail by nephrologists, and a little less, 39%, by nurse practitioners. And only 4.2% of the patients themselves considered themselves frail, whereas all of these patients, all 146 of these patients, met the criteria for frailty by the Fried's criteria. Now, in another study by Salter et al., older patients and women maintenance hemodialysis patients were more likely to be considered frail when they were not frail. These are elderly people and also women undergoing maintenance dialysis. Frailty is more common in older people undergoing maintenance dialysis who are being evaluated for kidney transplant, than in younger, namely those less than 65 dialysis patients. But prevalence was still increased in the younger dialysis patients as compared to the general population. So let me say this a little more clearly. Maintenance hemodialysis patients who are evaluated for a kidney transplant are likely to be frail, even if they're under 65, but particularly if they're 65 years or older. Now, one consequence of the frailty diagnosis is that frail end-stage kidney disease patients are 38% less likely to be put on the transplant waiting list. Doctors aren't stupid, they understand, and nurses, they understand what this is all about, and so they're more likely to reject the patient from the waiting list. The duration of time on the transplant waiting list, however, is also associated with increased frailty in many patients. So the longer people stay on the waiting list waiting for a transplant, the more likely they are to become frail during that wait. In chronic dialysis patients who are high risk, 59 years of age or older, diabetic, and or have more than 3 years of dialysis, both frailty and low physical performance were associated with increased mortality while they were waiting for a kidney transplant. However, not all studies confirm an association between frailty and mortality and patients on the waiting list. So some studies report this, other studies do not. Again, these are people on the transplant waiting list. In more recent studies, greater than 50% of kidney transplant recipients were considered frail, that's 20%, or intermittently frail, having some of the elements of frailty, 32%, together greater than 50%. This was at admission for their kidney transplant surgery. Frail recipients were 1.3 times more likely to be immunosuppressant intolerant and 2.2 times more likely to die post-transplant surgery. Frailty was predictive of mortality in 23 of 29 studies, that's 73%, that examined the relationship between frailty and mortality in people receiving different organ transplants, primarily the kidney, 36% of these studies involving kidney transplant, or liver, also 36%, but also heart, lung, or multi-organ transplants. So again, frailty is a bad prognostic sign if you've received a kidney transplant. Age was also associated with loss of kidney transplant and with death in patients who were inactive, smoked, had chronic obstructive pulmonary disease, peripheral vascular disease, or who had delayed graft function. Well, this, I think, is pretty obvious, but the fact is that frailty per se is associated with these same results. Now, can we prevent or treat frailty in kidney transplant recipients or in people just with advanced kidney failure who might be put on the transplant waiting list? To prevent frailty in kidney transplant recipients, the first rule, of course, is to prevent frailty in non-dialyzed CKD patients and in the chronic dialysis patients, especially in people on the transplant waiting list. We need to be proactive, I would argue, and prevent frailty from occurring in the first place. And this can be done often. Exercise training of frail stage 4 or 5 CKD patients can improve physical performance and trend toward improved frailty measures. This has been shown in a number of studies. Exercise training appears to be safe. And I'm going to show you some studies in exercise training in maintenance hemodialysis patients. But one needs to keep in mind that if you're going to try to treat frailty with exercise training, it is extremely important to first ensure that the patient does not have coronary artery disease causing angina or coronary insufficiency. There are occasional reports of angina occurring during exercise. One report of gastrointestinal hemorrhage during exercising and a number of reports, of course, of strained muscles. It is critically important to perform a cardiac stress test on every adult maintenance dialysis patient before starting exercise training. In my personal experience, about 10% of our asymptomatic maintenance hemodialysis patients had unrecognized ischemic heart disease as determined by the stress test. One person passed the stress test and experienced angina during exercise training. All the rest of the 10% of our patients, they were diagnosed with angina by exercise, by cardiac testing, exercise testing while they were receiving an electrocardiogram. So I cannot stress strongly enough that if you're going to exercise your adult maintenance hemodialysis patients, which I would strongly encourage, it is first important to subject them to a coronary artery insufficiency exercise testing program. I think this is critical, or sooner or later one of us is going to end up with dead patients during exercise training. Now, the study that we've carried out, we were patients who were studied for 10 weeks. They underwent dialysis and exercise training 3 times a week. During the first 90 minutes of dialysis session, we did it during dialysis so that we could monitor the patients and observed how they were doing. And during the first part of dialysis, people are hemodynamically stable. During the last part of dialysis, because of volume depletion, they become less stable. So we always did it during the first 90 minutes. We never had a single problem with any patient in terms of hemodynamic instability during dialysis. The initial target intensity was 50% of their peak work rate. And the target intensity was adjusted as tolerated. We pre-tested the patients to see how much energy they could consume riding a bicycle, and then we took 50% of the peak. The initial target duration was just 20 minutes of exercise. We're using we use electrically brake, semi-recumbent leg cycle ergometer, which it was done under direct supervision by an experienced exercise trainer. Now, this T1 refers to before the patient started exercise training. T2, I'm going to show you what I think are dramatic data. Of course, everyone thinks their research is dramatic, but maybe I'll be able to convince you that it is. And T2 is after 10 weeks of training of these patients. And this shows the difference in the VO2 max, the maximum oxygen consumption. It went up to by 15%, borderline statistically significant. The amount of work the patients could do, the amount of oxygen they consumed clearly went up, highly significant, went up 36%. The maximum heart rate increased significantly by 10%. The heart rate at end time was much greater, was again significantly greater, and the end, this is the end heart rate was increased and again significant, and this is the amount of oxygen being consumed at the end of the study, which was much greater again. Now this is straight, that was cardiopulmonary testing. We randomized patients in the type of exercise they did. This was the strength training, the resistance training, and again, leg strength, as indicated by leg extension. Again, the people who did the testing of this, these were deeply experienced, trained exercise trainers, professionals. This increased significantly by 14%. The leg extension power increased by 15%, borderline significant. The difference between strength and power is speed times resistance combined. Leg press fatigability, how many repetitions could they do at a certain weight before they could do no more? Increased by 44%, almost a 50% increase. Again, highly significant statistically. The four-step stair climb increased significantly again. the duration of time it took to climb 4 steps fell by about almost a third of a second, almost a half a second, by 14%. The speed of the 10-meter walk increased by 17%, and that's the time it took to walk 10 meters fell, again, by over half a second. And the time up and go, that's from sitting in a chair, standing, walking a certain distance, returning back to the chair and sitting down. And that time also fell significantly by 16%. Again, highly significant statistically. Now look at this slide. This shows the weeks of training. Again, they went up to 10 weeks before the study was stopped in these patients. And this shows the total amount of work. Please note that by the end of the first week, again, they were exercise training 3 times a week during the first 90 minutes of dialysis. By the end of the first week, they were already able to do more work. And look at how their work level increased progressively up to week 8. Incredible how fast this occurs. Now, what was this associated with? Were there any biochemical abnormalities that occurred in association with this? Well, please note here, this shows insulin-like growth factor 1 and a segment of the IGF-1 molecule called EA. And notice how the IGF-1, these are normals, and these are the dialysis, maintenance hemodialysis. These are our patients. We did muscle biopsies in the beginning, and the skeletal muscle, the quadriceps, the vastus femoralis muscle, in all of the patients. And please note how that their IGF-1 levels, this, as you know, IGF-1 is the most active anabolic agent induced by growth hormone. When you inject growth hormone into somebody, the growth hormone is not anabolic. It stimulates the elaboration of IGF-1. That's what's anabolic. And look how they're lower. The values were lower in muscle. The IGF-EC, no difference, very low in both. IGF-1 receptor, again, lower, significantly lower in the maintenance dialysis patients. No difference in myostatin. What is myostatin? Myostatin is a protein in all of our skeletal muscles, striated muscles, which actually inhibits protein synthesis and muscle hypertrophy. That's why it's called myostatin. It prevents muscle hypertrophy, muscle protein synthesis. What about IGF-2? Also lower in our maintenance dialysis patients. And IGF-2 receptor, no difference. Now, what happened during exercise training? This is before training, this is at the end. Note the remarked fall in the IGF-1 myostatin gene expression. This is not myostatin, this is the gene expression for myostatin. And note how it fell. It fell by more than half in our patients. IGF-1 gene expression increased significantly. IGF-1 receptor also increased significantly. All 3 of these changes are anabolic type changes. And this occurred in 10 weeks. In 10 weeks in our maintenance dialysis patients. Now we also looked at the number of binding proteins. We could not detect IGF binding protein 1. IGF-BP2 increased, as did BP 4, 5, and 6. No change in BP3. Now I have to confess that I don't really know in terms of anabolic effect what these changes in IGF binding proteins mean. I don't know. In serum, IGF binding proteins actually have anabolic effects, particularly IGF-BP3, but in muscle, I just don't know. But the bottom line of everything I've shown is both increase in muscle performance, muscle capacity, in the anabolic profile of skeletal muscle, reduction in frailty measures. Now, this is not my study. This is from somebody Dr. Castanedo et al., and he showed that with exercise training, resistant training, that's strength training, there was a reduction in serum C-reactive protein. It occurred slightly with low protein alone, much more with exercise training and a low protein diet. Serum IL-6 fell again with exercise training, as you can see here. Significant fall, highly significant. Serum transferrin also changed. These p-values indicate the difference between the resistant training and the low protein diet itself. And you can see that with regard, let me go back a moment, to CRP, and unfortunately you can't see this clearly, but there was a significantly greater fall in CRP and IL-6 with the exercise training than with low protein diets per se. And also significantly greater rise with serum transferrin than in exercise training. Serum albumin did not change significantly. There was a trend toward a greater increase with exercise training, but the difference was not significant. This goes back to our data, just summarizes it. When we characterized how the patients changed from the beginning baseline of the study to 10 weeks later, what we found was that, and I didn't show these data, but our patients were randomized to either primarily resistant training, strength training, or a combination of to cardiopulmonary training, that's endurance training, strength training, or a combination of endurance and strength. You can see that with endurance training, there was an improvement in one of the measures significant, that was cardiopulmonary. In strength training, there were 5 different measures of strength and physical performance that increased. With endurance and strength, all 6 increased in both. But if you're going to do one of the two, the strength training actually resulted in greater improvement in more different factors, a healthier profile than cardiopulmonary training. Let me put this in my words for just a moment. If I have a dialysis patient and I'm trying to rehabilitate this person, one of the things I want that person to be able to do is to walk. He doesn't have to walk 5 miles, but he has to get up and be able to walk to his or her car, drive to the market, be able to walk through the market. He's got to be able to pick up the groceries and put them from the car to the home and put them up on the shelves. That requires a certain amount of strength. So for me, I would much rather, if I had to choose between the two, I would much rather have strength training and physical performance increase than cardiopulmonary. That's just my personal opinion. Obviously, both would be better. But what I'm trying to say is that I think that just riding an exercise bicycle is not as good as resistant training for our patients. Now, this is a paper by Kirsten Johansson, who's now in Minnesota. And let me just summarize it. She looked, these are CKD patients, I think they're dialysis patients. And they are dialysis patients. And she looked at either those who got no treatment, those who got an anabolic steroid, nandrolone decanoate, that's nandrolone decanoate, those who got exercise training, and those who got both. The end result is that in comparison, look at these numbers, they hardly changed except for knee extension with the anabolic hormone. But look at the change with the exercise training, much greater, except for knee extension. There it was rather similar. But in other capacities, what I'm trying to say is in these, at least this one study by Kirsten Johansson, the exercise training seemed to be more effective at improving muscle performance than was giving an anabolic hormone. Now, does successful kidney transplant, let's go back to transplants now. Does successful kidney transplant improve frailty? There's a paper from the Netherlands involving 178 patients followed after kidney transplant up to 3 years. 125 patients, frailty was unchanged. In 19 frail patients, they became no longer frail. So essentially 10% of the patients became non-frail. On the other hand, 34 non-frail patients became frail, mostly due to cognitive and psychosocial functioning measures that became worse. So post-transplant, at least in this one study, some improved, but roughly twice as many did not improve and may have gotten worse. And most patients didn't change. What about exercise training of kidney transplant recipients? Well, there are not a lot of data, but this paper, which was published 2 years ago, and looked at a number, it's actually a meta-analysis of two or three different studies mainly, or even as many as 4 studies. And they looked at, and let me read this to you because it's hard to read from where you are. This is a physical function score, which tended to improve. This is the social functioning score, again, tended to improve. This is the general, this is the physical role score. These are health quality of life questionnaires the patients answered. It, again, tended to improve. In terms of mental composite score, no improvement. But 3 of the 4 measures showed improvement. Then they continued with the general health score, again, tended to improve, and the same with body pain score improvement, vitality improvement, and the role emotional score, no improvement. So in this health quality of life questionnaires, there was improvement with exercise training in these patients. Excuse me, I skipped a slide here. This is another study, again, involving 2 or 3 different studies in which they looked at, again, with exercise training, and these again are kidney transplant recipients. They showed improvement in the 60-second sit to stand. How many times can you rise and sit in 60 seconds? Rise from a chair and then sit down without using your arms to rise. There also was a highly significant increase in the 6-minute walk distance and a highly significant increase in the 6-minute walk test. I'm not really sure what quite the difference of these are. And also a trend toward an increase in the 6-minute, in the hand grip strength. This is hand grip strength. And I'm sorry, this is speed. That's what this is. This is distance. This is walk speed. This is hand grip strength tended increase. This is with exercise training of kidney transplant recipients. The disease data are still limited, just a few studies involving rather small numbers of people, 30, 40 patients. It does show that exercise training does help kidney transplant recipients. It certainly helps people who may be put on the waiting list for a kidney transplant. Now, there are very few studies of frailty on treatment in people who are kidney transplant recipients on their clinical outcomes. We're talking now about clinical outcomes, morbidity and mortality. Very few studies in CKD, ESKD, or kidney transplant. Similarly, anabolic agents such as testosterone, growth hormone, IGF-1, carnitine can improve protein balance in end-stage kidney disease patients. But in clinical outcome, there's no data. Exercise training in CKD and maintenance dialysis patients and kidney transplant recipients increases exercise capacity and quality of life, but has not been specifically tested in frail people with these conditions. The effects of these exercise training on morbidity or mortality in CKD, ESKD, and kidney transplant recipients has just not been tested. So, let me summarize and conclude, if I may. Protein energy wasting is common complications in patients with advanced CKD, end-stage renal disease, and in kidney transplant recipients. Measures of protein energy status and frailty correlate strongly with morbidity and mortality, correlate strongly in CKD and maintenance hemodialysis patients and in kidney transplant recipients. As kidney transplant recipients become older, the problem of frailty may increase in importance in those same individuals. Data indicate that both protein energy wasting and frailty often can be successfully treated in CKD 4 to 5 and maintenance hemodialysis patients. Exercise training appears to improve frailty in in kidney transplant recipients, as I just showed you. Finally, whether exercise training, better nutrition, and or anabolic hormone medicines given pre or post-transplant will reduce frailty and also improve clinical outcomes, that is, reduce morbidity and mortality in CKD, SKD, and maintenance dialysis patients and kidney transplants still must be tested. We just don't know. Great need for research to be done in this area. The field is wide open. We need help. Let me thank you very much for your kind attention.
No sé, algunos comentarios, preguntas a Dr. Kopple de la audiencia. Por favor, puede hacer la pregunta en español y se la podemos traducir. Anímense, por favor. Well, in the meantime, I wanted to ask you, what about relationship with the immunosuppression regimen? I'm saying, they use the avoid prednisone in this kind of population, as well as there are some relationship with the renal function. Because the renal function starts to decrease, seems like the patient is start to be malnourished. I don't know, can you comment about
that? Your question is, how does immunosuppression affect frailty? That's a question which really nobody has really looked at carefully. I actually was hoping to look at it at one point, and I just got sidetracked and I never did the research. But I'll tell you a couple of interesting observations that I didn't make, but that are in the literature. One is that people who are given large doses of glucocorticoids show tremendous mobilization of calcium from their tissues, loss of calcium. And giving those individuals growth hormone suppresses the calcium loss. It's my personal opinion that we probably should be giving either growth hormone or its product, insulin-like growth factor 1, or maybe testosterone, or another anabolic agent, to people who are getting intensive doses of glucocorticoids, and maybe some of the other immunosuppressive agents. But this has never been studied. This field is wide open. It needs to be addressed. But if you look at what happens to these, it's an interesting thing that the people who treat them during these acute stresses often don't follow them for months or years, or they don't put the two together. So we may be harming people in ways which are preventable, even though we're saving their lives. I'm not criticizing the treatment that's being done or these wonderful maneuvers that nephrologists and transplant physicians make. It's wonderful what's been done. But what I'm trying to say is that nobody is really looking at how the treatment's affecting either their protein energy status or their physical performance or their level of frailty. We really need to look into this. It's wide open. There's not a single paper I've encountered. It's waiting. It's just waiting to be addressed.
Okay, thank you.
I wish I were 20 years younger. Of course, we all do. No, not you young ones in the back.
¿Alguna pregunta? Aquí los nefrólogos.
Thank you so much.